I'm so happy to be here. This is a fantastic turnout. I agree. This is definitely the biggest group we've had, and the fact that you guys would take time out of your evening to come is incredibly humbling. So thank you for coming. Now, first of all, can people hear me okay? Is this kind of positioned? And do I disappear behind this thing? Like, that's the one. Maybe I'll put it like this so I can still see people and not have that fall off the thing there. There we go. Otherwise, I'm gone. Okay. So we have a few things that we're going to talk about here, and we kind of have broken it into sections. We have pauses as we go throughout where there's some natural stopping points to ask questions, but I do want to keep this as interactive as possible. So if I can see you behind the blinding lights that are shining at me, just put your hand up if you have a question, and we can kind of address it as we go. Otherwise, we'll be stopping from time to time to answer questions. But we'll try to keep this kind of informal, so please just speak up if you see something. If you have a question, say it. I'll repeat it mainly for the sake of people so they can hear it on the microphone, and then we'll go from there. So before we start talking about polycystic disease itself, we kind of are doing a bit of a background here, and it's important to know just what your kidneys do in general, because this is something that sometimes people don't think of too much. So the way to think about your kidneys is they're kind of the filters of your bloodstream. They filter out and get rid of all the wastes that your body doesn't want. Kind of amazing little facts that these little organs process on a daily basis. About 200 liters of blood are going through your kidneys. That's a good-sized bathtub worth of fluid that they're cleaning every day. And they just do it over and over and over again to process the wastes. Your kidneys do a whole lot of other things for you as well. In addition to just getting rid of the wastes, they play a role in a lot of hormone systems and other parts of your body. You can see things as diverse as making blood cells and controlling your bone health and controlling your blood pressure. So for tiny little organs, they do a whole lot in your body. Polycystic disease, and specifically tonight we're going to be talking about AD, PKD, or autosomal dominant polycystic kidney disease. That first part, that AD, reflects how it's inherited, and we'll talk about that in a second. It's a genetic disease, and as Jeff has said several times, it's very common. About 1 in 500, although that sounds like a rare condition, as far as genetic diseases go, that's incredibly common. A lot of genetic diseases we talk about are in the tens or 20,000s of individuals, 1 in 10,000, something like that. So this is a common genetic disease. We'll talk about the inheritance pattern in a second here, but what we see is that it's a disease where these cysts start to develop in the kidneys. And the cyst, since it's a genetic disease, this is something that happens over the course of somebody's life. Even in utero or before they're born, these cysts start to develop, and over time we see that they develop both in number. People get more cysts as time goes on, and they tend to increase in size as well. As a result of that, both of the kidneys start to increase in size from just all of these cysts accumulating. So the normal kidney without cysts is about the size of your fist. That's a good representation actually of your kidney. And when you see the extreme end of the spectrum here, there are people who have had kidneys with polycystic disease that are 10, 15 pounds each kidney. It's unbelievable how big these things can grow. So it can really range a huge spectrum there. In terms of what are those cysts, that's often a question that comes up. These cysts on the picture there that you see, those little bubbles are meant to represent the cysts. And they tend to come kind of scattered throughout the kidney. So if you looked at your kidney at kind of a microscopic level, it's made up of all these tiny little functioning units called nephrons. And each one has about 1 million of these, each kidney that you have. And what happens in polycystic disease is some of these nephrons develop these cysts, these pockets. It's actually a minority of them. You have 1 million of these things, and even someone with a lot of involvement of polycystic disease will have somewhere in the hundreds to thousands. So a small proportion of them will happen, but a small proportion of 1 million can still be a big number. So that's how it is that people can get so many cysts. The cysts start as a little pocket on this nephron, so it starts at a very microscopic level, and then over time it grows, and it fills with what's essentially fluid until it gets to the point where it's big enough that you can see it, like we see on the picture here. One of the questions we get commonly is that the cysts are just fluid. People often ask, what is this cyst? If you were to look at it, it's fluid, actually similar in composition to urine almost, or serum. So it's just a pocket of fluid. Very importantly, it is not a tumor or something like that, because sometimes people hear the word cyst and they think it's something bad. These are tumors that are forming or something along those lines, which isn't the case. If you were to look at it, it's basically a bubble of fluid that are scattered throughout the kidney. So this is what happens, and again, as time goes on, more of these accumulate, and the ones that accumulate tend to get bigger in polycystic disease. So one of the questions, and I think an important thing to answer, is what might you experience with this disease? And the answer, I think, is really anything goes, or anything is on the table. So we have some of the common symptoms that can come up with polycystic disease. Some of these are from the kidneys themselves. When you see for example, the middle picture, that has to do with feeling of fullness or heaviness. That can be from as these kidneys get bigger, you can feel that, so that you can have symptoms from the kidney size. Some people can have blood in their urine, which is from these cysts from time to time, can actually get weak and they can rupture. Even some of the microscopic ones in blood can come through. So those are from the kidney size. You have things like high blood pressure, often one of our first signs in polycystic disease. And that goes back to the fact that your kidney plays an important role in controlling blood pressure. So when something's happening in the kidney, it can throw that system off and the blood pressure can be very high. And then some of the complications that can happen within the kidney are things like infections. And this can be anywhere along the urinary tract, so it can be just a bladder infection like anybody else might get, or these cysts within the kidneys themselves can get infected and they can be a more substantial or a severe kind of infection. And kidney stones can be common as well. Anytime you have a kidney that has anywhere where there's an abnormal shape, and a cyst is a perfect example of that, if it has a little pocket somewhere or a little divot somewhere, that's a perfect place for kidney stones to form. So people with polycystic disease can have a lot of stones. So these are some of the early signs. Why I say anything goes is some people will have all of these. Some people will have none of these. Some people will have it happen early in their disease when they're very young. Some people won't have it happen until much later. Sometimes it goes along with what stage of the disease people are at, where their kidney function is, sometimes not. So it really is kind of a different variety. Every individual's experience is different with the disease. As time goes on, so that's earlier in the disease, as time goes on, then we do see the kidney size symptoms start to become a big thing. So as these organs grow, and they truly can become quite large, eventually people get discomfort or this feeling of fullness. A lot of people report that they can't eat as much as meals because they feel full very early, and that's just from the size that's happening in the abdomens. A very common comments that we get is that we hear all the time of our female people living with the disease who ask or who are asked if they're pregnant. Males who are told, oh, they just need to lose weight or they've got a beer belly or something like that, whereas it's actually from the organ enlargement inside that is happening. There are other parts within the abdomen that can increase as well, and we'll talk about that a little later on, and all of them can lead to abdominal fullness. So definitely something that as it goes on becomes a little bit more and more apparent or obvious. So we're talking about the disease course. One of the questions is, how do we even know this? How do we diagnose polycystic disease? So there's a group of people in which there's a family history, and it's clear-cut, and we'll talk about this in a second, where when one family member is affected, then a doctor will say, oh, your other family member should go and get tested. So that's kind of an easier thing. But that said, at least a quarter of people who are living with polycystic disease, when they show up to meet us as doctors, they have no family history whatsoever. So there definitely is a large group of people who come essentially out of the blue. Some of it is that with any genetic condition, sometimes somebody has to be the first one. You know, when a mutation happens, there's always got to be a first individual, and sometimes it happens to be the person sitting in front of us. But the other is that there may have been a family history, but nobody knew about it. And this is very common. I've seen this with a lot of my patients that, we identify that they have the condition, and then we say, oh, well, have your parents actually been tested? And they go backwards up the family tree, and lo and behold, one of them has it. In a lot of situations, it may be that maybe the parents have passed away, and it was the type of thing that people weren't really that tuned into or never really tested for before. So it could be that the disease was there, we just didn't know about it. So some people have a family history, some people don't. One of the things that complicates it, or that we need to think about when we're talking about polycystic disease, and I sometimes get referrals or questions from family doctors, is that not all cysts are polycystic disease. So there's actually a list of different things that can cause cysts in the kidneys. To have 1 or 2 cysts in a kidney actually can be quite normal, especially as people get older. They're allowed to have a couple of cysts. That can be quite normal. But then there are certain other conditions that can cause multiple cysts in each kidney. So it's important that this actually be assessed and looked at carefully. When we're talking about diagnosing somebody, we often do it with imaging. So at the bottom, we mentioned genetic testing, and we say that it can happen, but I'd say it's actually quite rare that we actually go down the road of doing genetic testing. And it's worth mentioning because it sounds funny for a genetic disease not to do genetic testing. And most of the reason for that is that it doesn't tend to change too much what we do, and we can make a very good diagnosis with a lot easier tests, things like ultrasounds or other scans. This is an example of an MRI on there. Now, when we do testing with something like an ultrasound or something like that, we'll talk about this maybe a bit again when we talk about family screening, but one of the important things to know about that is, if you remember earlier, I said that this is a condition where the cysts develop throughout the course of someone's life. They start off as being microscopic and then they grow in size. It's important to note because when we're doing testing, if we do something like an ultrasound early in life, in a child or a young adult, or if we can see a cyst on an ultrasound, we're very good at saying, okay, cysts are there, there's a family history of polycystic disease, this matches up. But if we don't see cysts when we do a test too early in life, it might not, we don't know if it's because the cysts aren't there or if because they're just too small for us to find. So although we say we talk a lot about using ultrasound and imaging tests to do it, to make the diagnosis, one thing we have to keep in mind is that if we test too early in life, sometimes we'll get a negative test, but it doesn't necessarily mean it's negative. What I tell all of my patients is, as a general rule of thumb, if they're tested early in life and it's a negative test, we can't completely rely on it. By the time they get to about their mid to late 30s, by then we can say for sure. If nothing's shown up by then, they're pretty much in the clear. But earlier in life, sometimes we have to do more than one test just to check into it. And I think we'll talk about screening in a little bit more detail later on. Now, in terms of the actual genetics of the disease, and this is almost due for an update now because it's just one of the exciting things that we've learned a lot about with PKD. So for a while, we've talked about 2 types of polycystic disease. And when I went through my medical training, this is what we would say. There's PKD1 and PKD2. And we would say that PKD1 is the more common one. In general, it tends to be a little bit of a faster disease course and have more complications. And when I say PKD1 or PKD2, sorry to take a step back, that's referring to the genes that are affected. 2 different genes that could be, there could be an abnormality in, a mutation in, and cause a disease. So PKD1, more common, faster disease. PKD2 would be less common, but a slower disease. So people with that would tend to not run into problems with kidney function until later in life. Why I say that this is due for an update, and we'll probably see this figure changing, is we definitely know that although on the whole PKD1 tends to be faster than PKD2, that's not necessarily the case. We definitely see people with PKD2 who have a fast disease kind of course. We see people with PKD1 who don't. So there's a lot of variability. Even sometimes within the same family, I'll come to that question in a second. Even sometimes within the same family, where we know everybody has the same gene because they're all family members, we'll see people who one has faster disease and one has slower disease. So we know this variability exists. And the other thing that's going to be updated, and this is kind of just the last couple of years, we've actually identified more genes. So it used to be when we went back into genetic testing, we would say, 10% of people had neither PKD1 nor PKD2. And we've now actually started to identify what some of those are. I won't go into much of the details, but there's something called GANAB, and there's a couple of other mutations, basically things that we had no idea even existed up until a couple of years ago, we're now able to identify in people with polycystic disease. And sorry, there's a question at the back there.
You may have answered it, but
It's a good question. So the question was, if we see family members who have different disease courses, one who's faster, one who's slower, one with more liver, one with less liver involvement, does that mean they have different genes? And we'll talk about this. Actually, it leads right into our next slide. So they all have the same gene. We know that within a family they would all share the same gene. It just shows us that what it's telling us is that the gene is only one part of the story. And this is why we don't often get a lot of genetic testing and why it doesn't tell us exactly what's going to happen in a person, because the genes you're given to have the mutation for polycystic disease is one piece of the puzzle. But we now know that there's all kinds of other things that influence how the disease is going to play out in an individual. So the genes is the genetic dice you've been dealt, but then other kind of environmental or health things can play a role into what kind of disease course you experience. Oh, and there's one more, yeah.
My question is, as you mentioned, there are two types of PKD, 1 and 2. One is fast, how fast it can be?
So it really runs the gamut, and and I don't, as I say, when I talk to patients, actually, when I'm talking about how fast it is, I don't say whether it's PKD1 or PKD2. So I would say on the whole, and we'll talk about this later in the talk as well, but it runs the entire gamut of, I have patients who are very young, kind of in their 20s, early 30s, and who are preparing for transplant. And I have other patients who live their whole lives, and they have polycystic kidneys, but they pass away in their 80s from something else and never run into trouble with their kidney function. So it's a huge range of different experiences that people can have. And we'll talk about this a little bit later on, but one of our main jobs as specialists when we see somebody is to try to figure out where do they fall on that spectrum as early as we can. Try to figure out, is this someone who's going to be faster or someone who's going to be slower? But it's really, everything is fair game, and we need to think about the individual in front of us because it's so much variability. So it was a nice lead into this next one of what does this mean in terms of the genetics and the family. So I think this is important, and I do like these pictures. They're great. Oh, good. They do. Yeah, they project quite nicely to the back. So we can see that we have a couple of individuals at the top there. We have the mother who's got the normal shaped kidneys, the ones that are in white in the outline, and the father who's got the dots, the cysts on the kidney. He's got the gene for PKD. The chances when someone has this of passing it on is exactly 50-50. It's 50-50 every time that they have a child, that the child will be affected. That's for each child, so it sometimes plays out that's why I call it the roll of the genetic dice. You'll see family members where there's 6 siblings and every single one of them has it, and others where it's truly closer to that 50-50. It's because every time it's like a flip of a coin. Every time they have a child, that it'll be 50% whether or not they'll have it. If the person passes on, can you see that? Oh, no, you can't see that pointer. If the person passes it on, so you see a couple of the children on the bottom have the cysts, then they also, when they go on to have children, it would be 50-50 that they would have it, and the process starts over again. So always exactly 50-50. This is where that D, that autosomal dominant, this is what the D means when we talk about this genetic disease. Very importantly, when people just generally talk about conditions or genetic conditions, they talk about things skipping generations and things like that. This is not one of those conditions. It's 50-50, and the person has it or they don't. So the 2 middle children, the ones who don't have it, they don't have to worry about passing it on to their children, unless they're extremely unfortunate that the children had, a new mutation or the other partner had the mutation. But when it stops in one branch of the family tree, it stops. Whereas if the child gets it, then it starts over again, 50-50 every time they have a child. We'll talk about this later. There's ways we can do the genetic testing, and there is, including if sometimes people are interested in doing things like if they're thinking of having a family or family planning and doing kind of either pre-implantation or post-conception testing. Those types of things exist. We can get into that more detailed conversation if you like later on. So this is why I really like that point that it says the number of people affected is entirely due to chance, because I definitely have some of these families that I know that there's 6 people and everybody has it. That's just that roll of the dice or that flip of the coin every time. But this is an important concept. So 50-50, and this is how it's passed on. And it kind of leads into the question of who and when to do the screening. So this is a very individual conversation, and it's something that I think is a conversation that really happens between you and your doctor and your children. Everybody kind of has this conversation together because there's upsides and downsides. So the upsides is that as early as we can know about it, there are some good things about that. We can identify individuals early. We can do that job of figuring out where do they fall. Do they fall more on the aggressive end or more on the slower end? And we can do that early on. We can strive to really work on things like their lifestyle and anything we could possibly fix. Like I said, there's the gene you've been dealt that a person has, but all the other stuff plays into the disease course they experience too. So we can say, let's work on all that other stuff as early as possible. So there's good reasons to do it earlier in life. There's downsides too, though. Some people have concerns about things like insurance. Some people have worries that the anxiety of knowing there's this disease hanging over their head or their child's head might be a lot. The insurance one I think is worth mentioning. For the most part, if you already know that you have polycystic disease, and if your child already knows that, whether or not they've been tested, they're kind of going to get flagged by an insurance company anyways. So I mentioned this one because it's often a big thought that people have. But if your son or daughter already knows that you have the condition, they would have to say that to the insurance company, and they're going to get flagged already. And they'll say, "Oh, what is that kidney disease?" And they'll have to tell them. And so to me, I think it's although it's a consideration, it's one that I don't think pans out as much. It's and often on the whole, we are trying to move more and more towards earlier identification. So this is an individual conversation. Again, I'll tell you my general spiel that I give people when they have young children. And again, this will vary individual to individual, so please talk to your doctor about this. But my general statement is that in early childhood, testing, if somebody doesn't have any symptoms, won't really change what we're going to do. And what I say by if they don't have symptoms in children, if they're feeling well, they have no pain or any other symptoms or anything like that. And the other thing in children is if they have normal blood pressure. That's an important one because when children go to see a doctor, people often don't check their blood pressure. So if those two things are normal, though, if they have normal blood pressure and no symptoms, I generally say, well, this is something that we're probably not going to change what we're doing early in life. This is a conversation you can have as your children get into their late teens or early 20s, which is a nice thing because then now you're talking about a young adult who you can involve in the conversation about whether or not they want to be tested. That's my general spiel. Things definitely need to be individualized, but that's the general rule of thumb. And, oh, yes. Yeah.
So how often do you recommend screening of kids? Like
Yeah.
my kids are 18, 20, so suppose they are negative. How often? After every year, 2 years, 3 years?
Sure. So what I would say is that, and again, this is not on an individual basis. My general recommendations for your individual spot, speak with your physician about it. But what I would say is if they have a test that's done, if we see the cyst, in other words, a positive test early in life tells us that they have it. We can say that very definitively. But if it's negative in their 20s, it's not something that I think you need to do every year or every 2 years or anything like that. I say if someone's had it in their early 20s and it was negative, I generally tell them, well, do it again in your 30s just to make sure. If in the meantime they're thinking about family planning, that would be the other time they might want to think about doing this. And that's the situation where sometimes we go down the road of genetic testing because it can help us really tease that out if it's going to make a difference for family planning reasons. Yeah. Great. Oh, and this kind of gets into the next one. So it says, if people are going to be tested, what's the option? Our first go-to is imaging and specifically an ultrasound. It's non-invasive. It's not like a CT scan or something that has radiation or dye or anything exposed with it. It's an ultrasound like people get when they're pregnant, so it's a very safe test and it's an easy test. There are certain situations, I mentioned that we do the genetic testing, but I would say that's the minority, at least in 2019, and that's the case across Canada. It's a very, very small percentage of people who get that done. It's usually with imaging, as I talked about. So again, the decision to get tested is a very personal one. And, I think my job as a kidney specialist is that I talk people through the pros and cons, and then they go home and talk with their family about what they want to do. And there's no right or wrong answer here. It's about what's right for your family. There are definitely people who do not want to be tested, and that's perfectly a reasonable thing to do. And that's where we say, well, these are the things you should probably do if you're not tested. You should probably get regular checkups. Blood tests and urine tests, the reason we talk about that is that often can pick things up earlier than a symptom might, right? A lot of people are asymptomatic or have no symptoms, so that can pick things up. Monitoring blood pressure is important, and we have a whole section later dedicated to talking about how to do that. But again, if someone is in their 20s, say, and develops high blood pressure, that's unusual. So run-of-the-mill high blood pressure that affects people unrelated to kidney diseases tends to happen in people's 40s and 50s, and that's kind of the big demographic or the big time in people's lives where that happens. But if somebody shows up with high blood pressure at a young age, we need to ask questions. And especially when we know that there's a family background of kidney disease, the question is what's making the blood pressure go high? And something like polycystic disease can do it. So that's why monitoring blood pressure is important. Being aware of symptoms and healthy lifestyle choices, and we'll talk about that actually in much more detail in a second, what those lifestyle choices are. When we talk about polycystic kidney disease, I think it's important that although the name says polycystic kidney disease, this is a whole body disease. There are different parts of the body that can be affected. And I really love this picture, and I've stolen it and used it in other presentations I give. That's what I'm taking from you, Jeff, is I steal your slides sometimes. I like that it divides it up to kidney-related and not kidney-related, because that's a very good way of thinking of it. Yes, the majority of things we think about are in the kidney, but there are parts outside of the kidney that can be affected as well. And we'll talk about some of these in a lot more detail, but it just shows that it's not just something that's limited to the kidney itself. And it's one of the reasons that when somebody has polycystic disease, we like them to visit with a specialist and have a good going over of all of this stuff so that we can know what to focus on in addition to just what's happening in the kidneys. We'll talk about a couple of these specifically in a second or a little bit later on here. Now this is the phase where we're still talking about early in the disease process and what do we do. So we'll be talking about diet, I know, later on, but we'll talk about a healthy diet and body weight, and I'll give you diet tips in a little bit in another section. Exercise is important. Exercise is also okay. People often ask, they say, I have polycystic kidneys, I have these big cysts, can I go out and do exercise, or am I going to make them rupture or something like that? And generally we'd say exercise is perfectly good. It's only high impact things that we really limit. You know, if you're playing rugby or you're a martial artist or something like that, that's where we say maybe this might happen. But otherwise, just exercise and non-contact or non-severe contact type sports are okay. Smoking, everybody should avoid smoking. Anyone with kidney diseases should avoid these non-steroidal. Anything else that's anti-inflammatory on the box, not for you. Throw it out. Tylenol is okay if you need something over the counter. Tylenol is the one to go to. And then blood pressure. We're going to talk about blood pressure itself. My favorite addition to this slide is the caffeine. Why it's my favorite addition is that people have actually done a study on this lately because we get asked this all the time. People say, can I drink coffee? And some very possibly just as caffeine addicted physicians like myself did a study where they actually looked at people depending on their coffee intake or their caffeine intake and found that even up to say 2 to 3 to even 4 caffeinated drinks a day didn't really tend to have any impact on how people do over time. So I'm not saying here to go out and drink 10 cups of coffee, but my general rule of thumb is that if I can have 2 or 3 cups a day, you can have 2 or 3 cups a day, and that's okay. We're going to talk a little bit about who the team is going to be, and then we'll get into some more specifics in a bit here. But I think it's important to know that this is a team of people. So every chronic disease, every disease that we think of, I think it's important to remember that there's not just a patient, there's a whole group of people around it. There's a family around that person and a community around that family. There's support organizations and the PKD foundations. I absolutely cannot say enough good things about the amount of support and resources that are available through the PKD Foundation. I think sometimes knowing that there's many other people, I mean, take a look around the room, knowing that there's people just like you out there living their lives, going through a similar thing, I think is a very important thing. And then there's a healthcare team. It's not just us. Why does the specialist have gray hair? I'm going to take that personally. But it's going to go home and I'm going to be counting hairs in the mirror at night. But it's not just us specialists. There's a whole team around it. Most of the day-to-day happens with a family doctor. In our kidney clinics or our other clinics, we have a whole team of people. We have dietitians, social workers, pharmacists, people who are just as important, if not more important, than what we have to say. So a whole team around you. And then the last part that's mentioned here in this part about early on or just when you found out about the diagnosis is just the impact of receiving the diagnosis. And I agree that the vignettes on the website are hugely powerful. It's, when we don't think about this enough as physicians. For us, it's a very routine thing to talk to somebody and say, as a kidney doctor, that's what I do all day. I tell people that they have problems with their kidneys, and I don't even give it a second thought. But as a person, it's a very life-changing thing to have a diagnosis and to have to unpack everything that goes along with it. And I think some of these stories of other people and how they've gone through it is very helpful as well. So we had our first section. We've broken this into sections, and this one is newly diagnosed or early in the disease process. We're going to talk about a couple of other things. We're going to talk about how do you manage the disease process, how do you live well with PKD, that's our next section, and at the end then we're going to talk about what happens if the kidney function starts to go down and what do the options look like then. But I think this is a good time to pause and maybe ask if there's any questions. We have some of these things that I think we've talked about them, but it's a good time to kind of pause and check in if anybody has any questions. I try not to be an intimidating person. I don't think I'm that scary, but please do just stop me along the way. I think we talked about a lot of these. I'm just looking through the list. These are good prompting questions. Talking to the family, I think, is an important thing, and we touched on that. We touched on the lifestyle, and we touched on the part about having children. That one's often a very particularly, it's a challenging thing to tackle. It really is. And I think sometimes as physicians or as healthcare providers, we don't ask people enough about this, and it's something that weighs on people quite heavily. So, do bring it forward, and there is a wealth of resources out there to look into. Okay, if not, maybe we can launch the next one, and this is probably going to be one of the bigger sections here. So, how do we live well with polycystic disease? So there's a few things that we're going to talk about, and I'm going to spend some time on each of these. There's the management of the disease itself and how we slow down the process of what's happening. And then there's how we manage complications and other things that are associated with the disease. So diet, this is probably one of the biggest groups of questions that I get. And this is why I'm not exaggerating. There were people, some of the healthcare providers who were in this room, know that we just had a meeting before this. We had an educational session with all of our kidney clinic teams and things like that. I'm not exaggerating to say that I think the dietitian is probably the most valuable person that I have in my clinic, because so much of the questions come to this. So I will try to do her justice by answering this. So people often say, your doctor might say, well, just have a general good, healthy diet. And what does that mean? So there's a few things to unpack here. So in general, if you're looking for a template, I think a good place to start is to find a heart-healthy diet. The reason I mention that is if you go out and Google kidney diet, you'll find that a lot of them apply to things that are for people with very low kidney function or people who is on dialysis or something like that. It's important because you'll find things like a lot of talk about potassium and a lot of talk about phosphate and things like that, which is really for people whose kidney function is lower. Those most kidney diets that you Google are not about keeping kidneys healthy. They're about what happens, what do I do when my kidney function is already low? So if you Google the term kidney diet, whereas a heart-healthy diet, most of the same things apply actually. And more you'll see that there's going to be resources specifically for polycystic disease. Here in BC, we're just developing some of these, and before long, they're going to be available on our website of exactly what should you be doing as someone living with polycystic disease for your diet. But so that's a good place to start, a heart-healthy diet, and we'll talk about some very specific things. So fiber is good. Nobody gets enough fiber. If you think you get enough fiber, you're not getting enough fiber. You can always increase it. So that's one of the big take-home messages there. We talk about carbohydrates and trying to minimize that, and that's probably just good advice for most people. But we do need to kind of make a trade-off, and the trade-off, when you're talking about either carbohydrates, is it's got to go somewhere. So the calories have to come from protein or fat. Protein is a very important one to think about. So what we generally recommend to people is not to limit their protein, but to have a normal level of protein in their diet. It works out to, the numbers we use is something like 0.8 to 1 gram per kilogram of body weight. If you're a tracker, that means that if you're looking at somewhere, depending on your size, of between 50 to 80 grams of protein. So those are just numbers. That's a bit hard to kind of wrap your head around. I think that in addition to the other thing I want to say about protein is I specifically said it's a normal amount of protein in your diet. We try to avoid high protein consumption. We definitely avoid things like protein supplements. We have people, some patients I have that do some exercising and take various protein supplements, things like that. Most of those are just not good. And unless you specifically are having trouble with your protein intake, probably you should stay away from those for a whole host of reasons. Those things that the bodybuilders use, not good stuff. And some of it's quite hard on the kidneys. But we also, so you don't want high, but you also don't want low. And that's an important point because some people who have kidney diseases, your doctors will tell you, oh, there's some protein in your urine. And when we do a test, we can see that there's protein coming through in the urine. And so the natural reaction there might be to limit the amount of protein that you have in your diet. You say, well, it's coming from somewhere. If I don't eat as much, then it's not going to come out. And that's not the case. And actually, you do need protein to maintain good health. So protein is important. While we're talking about protein, the other thing that we say is there's a couple of different places you can get protein from. You can get protein from animal proteins, or you can get it from vegetables, plant-based proteins, vegetables, legumes, nuts, lentils, things like that. Gram for gram, plant-based proteins are probably better than animal-based proteins. So one of the big things our dietitians often talk about is trying to move away or shift some of that protein intake from an animal-based to a plant-based. And there's a lot of other health benefits that go along with that. Some of the things we talk about, like fiber, and some of the other good stuff that comes with these plant-based proteins, often tend to just be generally healthy foods to begin with. And it's not. Salt is not on there. So when we talk about diet, and maybe it's because it comes later, number 1, 2, and 3 is salt. When I talk to my patients about things to limit the diet, it's salt, salt, salt. And the question is always how much, what salt intake should be going for. If you follow even in the media, sometimes they say, well, doctors keep debating what's the salt target. That's kind of a loaded question because what the debate seems to be is what's the upper limit of salt intake that we should expose a human being to, which I think is the wrong conversation. The thing I tell my patients is you're never going to meet someone in Canada who's salt deficient. So in other words, the lower, the better is what we're going for. When people think about salt, they think about the shaker on the table and they say, well, I never add salt to the food. The important thing to know about salt is most of the salt that we have in our diets comes from what is already in there. The vast, vast majority of that is from pre-processed or pre-packaged foods. So, that whenever they do studies on this, over 3/4 of our sodium intake comes from that type of stuff, something that you buy at the store that comes in a box or a can or a bag or something like that, something that's been processed. If you get into the habit of preparing most of your things fresh, you've fought most of the battle in terms of eliminating salt. That's easily the biggest thing. And then what you add at the table or when you're cooking, if you're making things fresh, is minute compared to what's already in processed foods. So it's not to say you can never have any of those because there's a reason that they exist, these convenience foods, or you go out to a restaurant or things like that. Not to say you never do it. When it comes to dietary management, it's all about what you do in your day-to-day. And doing the right thing in your day-to-day, that's what lets you have a cheat day every now and again. I can say this because the dietitian's not in the room, but I think she knows I say this too, is that the way to stick to dietary recommendations, every now and again you can have a treat. It's all about moderation. If you're doing the right thing most of the time over many years, that's what pays off. And so salt, salt, salt. I just noticed that wasn't on this slide, but that's the biggest thing. Get in the habit of anything you're buying to look on the back. They make it very misleading to look at salt on packaging. And it's intentionally so, right? The food companies do this. They put salt in everything because it's a cheap way to make food taste better and last longer. So that's why it's in everything you buy. And the labeling, they've fought hard to make it very confusing. And if you notice, everything's listed in percents of servings and percents of daily intake. The percents you see are percents of a very high salt diet to begin with. And the servings are often misleading. You'll say, you know, for the example I use is people go out and buy instant noodles, these, you know, ramen noodles. And if you look at the salt on the back of this, it's already incredibly high. And then you look at the serving, and it says that's for half of a package of this. Well, who has half of a package of this? Nobody's eating half of that. So the serving size is something you take into account. So definitely, I've talked a lot about salt, but it's because it's probably one of the biggest things to be mindful of. And then water intake we're going to talk about in a second. And you can see, I hope I've done it justice, but there's so much that plays into this that this is where I think having dietitians involved and getting some of that advice can be very, very helpful. So that's diet. And then there's exercise. So this is the other big part of lifestyle. And as I mentioned earlier, it's really only high contact or high impact activities that we tell people to limit. Most of your general day-to-day exercises or activities is perfectly fine, actually, and definitely beneficial. It has all kinds of good effects on things like blood pressure and just your general cardiovascular health, your heart health, and overall well-being. So it's very important and something that I think everybody should be doing. It's only those high contact sports. And it's not to say people can't do it. I definitely have patients who engage in some of these sports. It's just knowing what we worry about is that those cysts that people have on the kidneys actually can physically rupture like a balloon popping. And it's possible with a high enough impact to do it. It takes a high impact because your kidneys are deep inside of you and kind of well protected by your rib cage and everything, but it is possible that they rupture. So I have some patients, you know, I've got patients who play lacrosse and rugby and things like this, and they say, well, you know what, I love it. It's something that I know might happen every now and again, and I'm going to go ahead and do it. And it's not to say you can't do it, it's just this is why we talk to people about it. And definitely if you're engaging in something like that, I think talking to your doctor about it on an individual basis is an important thing. But then otherwise, yeah, exercise is a fantastic thing. I think sometimes it sways too far the other way where people who have these cysts feel like they can't do anything because they don't want anything to happen, and that's not the case, and exercise is, of course, important. I think I see a hand. It's hard to tell under the spotlights there, but... So the question was, if one of those cysts were to rupture, what's the consequence of that? So a few different things. So it tends to be kind of dependent on where the cyst is that ruptures. So sometimes the cyst ruptures and people don't notice. Best case scenario. Other times it can come with symptoms along with it. Sometimes it could be pain, and it can be quite severe pain. People say that they're walking down the street and it feels like they've been shot or something, you know, that just sudden pain from a cyst rupturing. Sometimes there's no pain, and when one of the cysts ruptures, if it happens to be near the draining part of the kidney, people can get blood coming out in their urine. And it can be any combination of those things. So it can be different for different people. It doesn't, unless it's a very bad or complicated course with it, it doesn't impact or worsen how the kidney is functioning. It's that cyst itself, that little bubble that pops, but the kidney, it's not like it makes the kidney shut down or anything like that. It's more the pain or the bleeding that come along with that. Yeah. Oh, there's, yeah.
So what happens if one does rupture while you're walking? I mean, how long does it last? What can you or should you do?
Right. So the question was, if this happens to you, what do you do? So people, unfortunately, I have patients who've become quite accustomed to this, that they've had a few of them happen. And they say, well, I know what the score is now with this. And I think there's two things that we may need to manage. Pain, if it is uncontrollable, severe pain, we can't assume that that's from a cyst, so I don't tell people to ignore that. And if you're having uncontrollable severe pain, you need to go see a doctor right away. Some people have blood in the urine, and some people, it can be very dramatic when all of a sudden blood starts coming through and when you pass your urine. If you see that blood comes through and it kind of goes away right away, that was a one-time thing. It can be very dramatic. Think of it like if you have a nosebleed and a drop of blood comes into a bowl of water, it looks like a lot. So it's hard to say how much is coming through. Again, some people, as they get used to it, they say, oh, well, that's some blood coming through, and then they carry on. But also, if it's something that's never happened to you before and it's dramatic, just please see a doctor about it, you know, and then we can sort through time to time. Most of the time, we actually just support people through this. So if they need pain medications, we give them pain medications. When people have bleeding, it's rare that it's to a point that they need things like a transfusion or a procedure to fix the bleeding. It's essentially we kind of control the pain and wait it out, and it goes away. But definitely these are things that if it happens, you should talk to your doctor about. I don't want to give individual recommendations. This is kind of some of the things people can experience.
Supposing though you're out on a hike and you're nowhere near a doctor, I mean, do you do anything for the first 5 or 10 minutes? Just sit down and rest?
Yeah, that would be the general, as long as you're otherwise feeling okay and not, dizzy or lightheaded. Again, if something happens, kind of general emergency principles, apply, that if you're feeling unwell or you're faint or things like that, that's a whole different story. Then some people, as I said, as they get used to it, if they've had some of these, they know how to manage it and they kind of just carry on about their day. But I would not say that about everyone. I would say the right thing to do always is to try to get yourself some help. Yeah. Oh, yes, and one more question.
Is there a possibility of spontaneous rupture of this cyst while you are resting?
The question is can these cysts spontaneously rupture? The answer is unfortunately yes. So definitely I've had patients who've just woken up in the night and felt something and it can happen. Yeah. I don't want to scare people with this. It's a reality of the condition that it can happen, and a big part of it is we support people through this, and definitely it's something we want to hear about. So I don't think any doctor would be say you were out of line if you called your doctor because you were worried that you started passing blood in the urine. I think they would say come on in and let's take a look. Yeah. Oh, there's one more question at the back there. So the question was, after the cyst burst, does it kind of affect the rest of the kidney? And the answer is not particularly, actually. A lot of these cysts are kind of bubbles of fluid, so that part is not doing any of the kidney function. So if it bursts, that part bursts, but it doesn't tend to affect much of the kidney function itself. Yeah. All great questions, so please keep them coming as we go. Right, so as we're talking about lifestyle management of this, the next part is water, and this gets asked a lot. And it's something that we've been studying on and off. There have been studies that people have done. Some have said it's good, some have said it's not clear. There's actually some properly well-done big studies looking at this, just how much water should somebody who's got polycystic disease be drinking. And there's a couple of reasons to do this. So one is that nobody drinks enough water. If you think you're well hydrated enough, you're probably not. This is just the general population. We know that water can decrease some of the things that people with polycystic kidneys are at risk for. Things like kidney stones or infections. Drinking lots of water, keeping things moving can decrease the risk of that. So those are general reasons people might drink fluid. We specifically think about this in polycystic disease because one of the things that determines how the cysts grow in somebody who has polycystic disease is a hormone in your body that's related to water handling and thirst. So it's almost like we're trying to trick your body into never being thirsty to shut off this hormone. So it's one of the reasons that people talk about drinking water as a way that might actually slow down polycystic disease. We're tricking body's hormone system into shutting that off. And in terms of how to do that, it's a bit unclear. People always want a number, and this is where this 2 to 3 liters, I'd say at least actually 2 to 3 liters, if not more. I say at least 3 liters. That's where this number comes from. But more importantly is that when we say enough to maintain kind of a pale urine color, what we mean by that is that it's making it so that your urine is what we call dilute, which is what this hormone cares about. So as you know, and you've probably experienced this, if you go all day and don't drink any water, your urine's going to be very concentrated and dark, whereas if you've been drinking lots, it's kind of like water. You want to aim for that like water color. And the more important thing than how much you're drinking is that you are drinking all day long. So I'm guilty of this sometimes. You go to work and you've been at work all day and you haven't had a thing to drink, and it's been 8 hours before you know it. And then even if you go home and drink 2 liters of water after you get home in the evening, you're still not doing yourself many favors because that time that you went dehydrated during the day is when these things tend to happen. So it's more important to be spreading your water intake through the course of the day. It's something that people I think need to almost make an effort for and to train themselves to do. One of the practical tips I give for this is that if you can get a water bottle, and they have some of these big water bottles. One of my patients showed me one the other day. It was like a milk jug the size of this thing. You don't need to go that extreme, but they have big water bottles. Fill it up, put it in the fridge at night, and then tomorrow it's your job that you need to drink that through the course of the day. Have it with you at work, and it's your job to kind of get through it. And eventually getting into that habit, you train yourself to drink more water. Oh, yes?
Does drinking
Ah.
carbonated water make any difference?
I'm sorry?
Drinking carbonated water?
Oh, does drinking carbonated water make much difference? Every now and again, I would say that's okay. On the whole, we definitely say water is water. Now, nobody's looked at this, but in general chronic kidney disease, we actually try to aim for a diet that's more alkaline as opposed to acidic. And carbonating the water does tend to make it a little bit acidic. Now, nobody's ever looked at this. Are you better off drinking fluid even if it's acidic or not, as opposed to no fluid if you really find it unpalatable? But on the whole, so as an every now and again thing, I would say that's okay. But on the whole, I would say just water. And try to do other things to flavor it. Because it's true, drinking just water all day long can get kind of boring. This is where things like adding lemon or cucumber or something to it to kind of, give it some flavoring and mixing that up, I think helps. Every now and again is fine, but I would say I wouldn't want people drinking 3 liters of carbonated water, every day. Yeah. So as we're talking about managing and living well with polycystic disease, I love this slide. I think I need to make it animated somehow. Because we've known about polycystic disease for a long time now. And when you look back at this, actually it was first described about 200 years ago. That's a long time to know about anything. But for many, many years, we didn't have a whole lot. So from 1820 to about 1995, nothing really changed. We knew that polycystic disease was a thing that existed, and it was described in medical textbooks, and that's about it. And then we started finding out that there are genes responsible. That was the stuff that I talked about earlier. And then a lot of this timeline is embarrassingly blank. So if we did a timeline like this with years put out for something like, say, heart disease or certain types of cancer, you wouldn't even be able to see the white space on the back. It would just be littered with different studies and drugs and trials and all kinds of developments. The one for polycystic disease has been embarrassingly blank for some time. But now, over about the last 10 years, people have been doing studies on it. And back in 2012, that's when the first one came out that actually looked like it was doing something. There was a drug that was studied that looked like it was slowing the disease course down. And then we see other studies coming out. We see studies on blood pressure. This is now about the medication again. There's actually been 2 trials of this medication. And there's a slide that I use when I give talks that shows that right around the 2012 mark, when this first study came out, if you're to look at how many studies per year are happening with polycystic disease, right around that 2012 mark, it starts to skyrocket. And I think it's worth pausing on this for a second about why this is happening. So in medicine and as physicians and doctors, we see new drugs all the time. That doesn't even make a blip on our radar. Somebody will send us an email, some drug rep will come out and say, I've got this new blood pressure pill, and say, yeah, that's very nice, good for you. I've got 20 other blood pressure pills, it's fine, thank you very much. So a new drug doesn't even register as a blip on our radar anymore. So sometimes we see new drugs, not too exciting. Sometimes we'll see what's called a first-in-class drug, meaning, here's a whole new group of medications that we never had before. A new area, a new family of pills, a new family of medications. Like, okay, that's kind of interesting. It's much more interesting than the same kind of family of pills being recycled over and over again, so that perks us up. So that's called a first-in-class drug. It's very rare that we see what's called a first-in-disease drug, and this is it, meaning that we have a disease that has gone from having 0 disease-modifying treatments to having a treatment. That's a very exciting thing. To go from something that we say we have no specific treatment to having a treatment, that's something that changes the landscape. And that's why it's not just about this one drug, which I'll talk about in a second. It's exciting, don't get me wrong. But it's why if you look at the amount of research happening in polycystic disease right now, it's why it's skyrocketing. Because as soon as one person shows that there's something positive they can do, all of a sudden, just like people living with the disease have hope, the scientists have hope too. They say, actually, it looks like things are starting to work in this area. Let's get in there. Let's do our studies and let's try our drugs. And now there's all kinds of different things. If I was to show you the active trials happening, you would see that for the first while there's nothing. And then after about 2012, they just start appearing like flies on the screen. You would see all these little dots there because flies probably isn't the best word, but it would be scattered all over the place because excitement happens and research is happening. So what is this drug that I'm talking about? It's something called tolvaptan, which works on blocking a hormone called vasopressin. That's the one I was talking about earlier, this one that has to do with water and thirst. So it works by blocking that. And what we know is that vasopressin, which is a normal hormone your body makes, there's nothing bad about this hormone. It just happens to stimulate the growth of these cysts in polycystic disease. And that's eventually what leads to kidney damage. So what this drug does, oh, look at those animations, is it blocks that hormone from having that effect. And by doing that, it takes away that signal that's telling the cyst to grow. And by doing this, then it can help protect the kidneys in the future. Now, one of the other things that hormone does, as I talked about, is it controls your body's water handling. So what it does is it actually makes you, when you block that hormone, people start peeing a lot more. So it takes, remember we said if you get dehydrated a bit, your urine concentrates and gets darker. It kind of takes away your body's ability to do that, so that no matter what, it's passing lots and lots of urine. And as a result, then people are drinking more to keep up with what's coming on. So this would be the main side effect of this medication. It's something that people have to work into their lives. It does require a change. When we talk about how much this is, we generally say on average it kind of doubles the amount of urine you have to pass. I have patients who have had a lot more, patients who have had not much of a difference, but it definitely increases the amount of urine you have to pass. So because of that, it's not just like, say, a blood pressure pill. We start a blood pressure pill and off you go. It's something that I think people need to work into their life a little bit more because it has these day-to-day consequences. It's one of the reasons that, people on this, where'd I go? The people who are on this treatment, I think being in a good kidney clinic with support that can help people manage this and work this into their lifestyles is important. Now, because of this, because of the side effects that come along with it, this is not a drug for everybody who has polycystic disease. And I want to be fairly clear about that. Because sometimes people will say, oh, well, I know so-and-so has polycystic disease, he's on this drug, but I'm not on this drug. Is it because my kidney doctor doesn't know what's going on or whatnot? And it really is because it's not indicated for everybody. I was on the group that wrote the recommendations for using this in Canada, and we're quite clear about that. And actually, it's mainly reserved for our people who are more rapidly progressing. And that comes back to that thing we were talking about earlier, that spectrum of disease, where some people have very slow disease. Let's go to that one extreme. If we have people who have very slow disease and are going to happily live their lives and pass away when they're 90 years old from something else with kidneys that still work, the last thing we want to do is put them on a medication that causes side effects for 20 or 30 years of their life, and at the end of the day, actually, it never would have been a problem for them anyways. So this is the reasoning that we say it's not for people who have slower disease, it's really for those ones who have more rapid disease. And there's a few different ways that we get to this, that we figure this out. And some of it is looking at some of their tests, like imaging tests, things like blood pressure, what's happened in the family. Somewhat might tell us, but it's not perfect. So definitely I would say it's not a treatment for everybody. And it's something that definitely needs to be thoroughly assessed. And you can talk with your kidney specialist about this. Blood pressure is the next subject. This might be a time to pause because I often do get a lot of questions about this medication. Oh, yes.
Is there any difference between the strength that the drug is administered? I mean, with a lower strength, maybe have just partial effect.
Right. So the question is there any difference between the strength and what the effect it has? And do you mean in terms of the side effects? Like maybe we can get away with less side effects and still have the effect?
Yeah.
Yeah.
Maybe slow it down a little less, but
but not so bad that you get the side effects. Yeah. So it's a very good question. Now, some of this, and I won't get into the kind of medical details about this or the scientific details about it, but one of the ironic things about it is that we're just learning to assess how people are responding to this medication and who's a good responder. This is the future of when you hear about personalized medicine, and it's buzzwords that are out there in medicine, but this is actually what it means: is how is someone responding, and is this a good treatment for you as an individual, not just anybody who has this disease, but you as a person. One of the things that tells us how someone's going to respond is actually the difference in that concentration of the urine that I was talking about. And I won't get into all the details, but the long and short of it is that people who have the biggest change in that concentration have the best effect. That also is exactly what produces the side effects. So the ironic end of it is that the people who have the most side effects from the medication are probably the people who are benefiting the most from it. So the short answer is there's not really a way to divorce the side effects. I actually say it's not the side effects of the medication, that's the effect of the medication. This is actually what it's doing. So there's not really a way we can separate that out. You can't have one without the other, unfortunately. Oh.
What about the duration of medication, like 1 month, 2 months, or 1 year?
So the question was about the duration. So once someone's treated with this medication, it's a long-term thing, as long as they don't run into side effects or problems with it. So it's why we actually go out of our way to really think about this before we start up this medication on somebody. Because, again, that's why I say it's not like starting a blood pressure pill. We do this all the time. Start someone on a blood pressure pill, walk away, that's that, Bob's your uncle. We know we're going to be inducing side effects that people are going to have to live with for many years in a lot of cases. So that's why we really want to talk to people and why it's important to have this conversation with your doctor about whether this is a right fit for you or not. Because it's not just signing up for something for a week or a month or something like that. It's a long-term treatment. Yeah. I think there's one in the back there. Yep. The question is, aside from the increased urination, is there other side effects? So there are some other side effects, things like if people have problems with gout or things like that, and electrolyte problems, but that's all quite minor compared to it. The other main thing that we look out for is when people, and this isn't on the slide here, but when people are on this medication, a small percentage of them can actually, this medication can cause some damage to people's livers. Now, if this happens, it's a reversible thing. So it's not permanent. It's a reversible thing, meaning if this happens, you just stop it, and that's that, no permanent damage. But because of that, we have a system in place where if someone's on this medication, they have to have blood tests taken every month for at least the first couple of years to make sure this isn't happening. So that's another thing people have to work into their lives, is getting blood tests done once a month to make sure things are okay. So there's a lot that comes along with it, and definitely it's an individual discussion about, is this a good fit for me? This is not for everybody with polycystic disease, and actually we don't have the exact numbers, but most would say it's actually for the minority of people with polycystic disease. It's with the most aggressive forms. Okay, so the next thing we have to talk about is blood pressure. Blood pressure is very important. Blood pressure can definitely slow down this disease course, and blood pressure control, that is. And it's an important thing. And I think it's worth mentioning because sometimes it got lost in all the sexiness of having a new drug out there. That blood pressure, it's regular old blood pressure, it's boring, nobody gets too excited about this. But we actually have very, very good studies that show us that controlling blood pressure slows down growth with polycystic disease. So the first thing that we need to do to control blood pressure is just know what your blood pressure is, just monitor your blood pressure. So this is why I say it's important to monitor it. When people go and visit physicians, it happens, it happens with my family doctor. I can't remember the last time they checked my blood pressure. People are busy, it doesn't always happen, so it needs to be checked. And one of the ways that you can do it is you can actually take ownership of it and check your own blood pressure. And I'm not just saying that because physicians are lazy and we don't want to check your blood pressure. We know actually that checking somebody's blood pressure when they come to see a doctor is probably the absolute worst time to check their blood pressure. Because you've just driven in and, you had to maybe sit in the waiting room with like the 10-year-old Reader's Digest, and you're a little bit upset that you've been waiting, and, you had to find parking and all this. And even if people don't feel nervous, we know everybody's blood pressure comes up when they're in a doctor's office. Whereas actually people have done studies on this, and the most accurate way to measure someone's blood pressure is to do it at home. So we sometimes send people home with a monitor they can wear, or you can buy these little monitors now, and it's definitely something that I recommend to people. And the nice thing is they've come down in price incredibly. You can get a pretty accurate one for like $30 or $40 at Costco. And they all work very well. You do not need, you'll go online and you'll see these big fancy ones that have Bluetooth and connect to this and graph your results and stuff like that. And you can spend an arm and a leg on it. But actually we have one in my office, we have one that looks almost exactly like that picture, and it costs like $35 and it's very accurate. And that's all you need. And it's not the fanciness of the machine. It's just the fact that you're measuring it at home when you're relaxed in your normal environment. That's what makes it accurate. The real time to check your blood pressure is when you're at home, sitting on the couch, haven't done anything for the last 10 or 15 minutes, and then you check it. If you're checking it at home, it's not something I tell people not to obsess about. When I see someone, sometimes I tell people this, they come back and they've got this record of blood pressure they've been checking 8 times a day, and then you think about it and the blood pressure goes up, and that's not a road you want to go down. You check it a couple times, even a couple times a week, so you have an idea of where it's at, and you write it down and you bring it in when you see your doctor. That's probably the best way to manage the blood pressure. So recording at home is great. If you're going to buy a machine, like I said, you can get them pretty inexpensively at Costco or something like that, anywhere really. There's a couple different ones out there. They have these fancy ones now that go on your wrist instead of on your arm. Those wrist ones are no good. They're not as accurate as the arm ones. So they look fancier and smaller and everything, but they're not as good. So get one on there. And if you're going to buy one, if you look on the box, there should be a little heart that says Canadian Cardiovascular Society. There's a little picture of a heart. That's how you know it's a good one. It's been tested. It's a good blood pressure monitor. So when we treat blood, or when we see blood pressure, we monitor it because we want to know if it goes high and if we treat it. And actually, there's in the general population, we're sometimes a little bit loose about our blood pressure control, in that, someone who doesn't have kidney disease might come and see their physician. We say, well, that blood pressure is kind of good enough, and not too bad, that's fine. And then we send them on their way. In somebody who's got polycystic disease, that is not at all the case. We definitely want to be aggressive about it and control it quite thoroughly. So that's a reason that even when you visit your doctors, they may even talk about having you on a lower blood pressure target than most people. It's because we do have efforts to really drive it down in polycystic disease. And there's many different ways that we can talk about it. We have a slide for this. I don't want to get too much into the nitty-gritty about different blood pressure pills, because I would say this is something that's very individualized, and this is between you and your physician. The important thing, the take-home message is blood pressure is important, and we definitely try to control it aggressively. Monitoring it at home is the best way to do that. So I'm just going to actually skip that over. Pain, we've talked about a bit here. Now, the questions are, what causes pain and what can we do about it? So we talked about the cyst rupture already. I think we covered that quite nicely, actually. It says here that kidney growth can cause pain, and I think it's worth mentioning there's 2 kinds of different pains almost that people end up with. There's a grumbling, kind of always there, fullness or discomfort, and then there's these episodic or every now and again bad pains. And they're kind of different things. The kidney growths themselves is often, as the organs get bigger, is that discomfort, fullness feeling, whereas these sudden episodes are those sudden pains. The management, as we say, for these acute pains, I'd say you just need to see someone at the time, because there's different things depending on what the cause of it is. And then the trickier one is the chronic pain. It's something we're trying to address better and better. I think it's a gap in our care right now, honestly, is how to manage that ongoing pain or fullness that people have. But we'll talk about a couple of the very specific things. So there's kidney stones. So kidney stones are very common, as I said earlier. Because of the shape of the kidney, people tend to get stones. Some of them people pass on their own. They tend not to be a subtle thing that people pass without knowing. In other words, you'll feel it. They can be painful, so people know. And bigger stones may even need treatment to get it out. The single biggest thing you can do to prevent stones from forming is drink lots of water. And this is true for anybody who's had kidney stones. So it just happens that matches up nicely with what we already talked about. Drink lots of water. And this is one of the additional benefits. It helps prevent or decrease the chance of kidney stones. A lot of the diet modifications we would talk about also tend to be general healthy diet, like low salt. So already we're talking about the same type of diet changes. Liver cysts, I think, are an important one to talk about specifically. It's a complex combination of things. So having cysts in the liver is very common in people who have polycystic disease. About 80% of people who have polycystic disease are going to have cysts on their liver. The vast majority of those people, the liver involvement is not all that major. But there's a group of people for who the liver involvement is the predominant thing, and in some cases, even much more of an issue than their kidney disease is. So it's kind of a strange combination in that it's incredibly common. It doesn't cause big problems for a lot of people who have PKD, but the ones who it does cause problems for, it causes really big problems for. So it's kind of that combination of things. And it's another one that doesn't tend to track perfectly in families. We see some families where everybody's had a lot of liver involvement, but you'll see some where one person has a lot of liver involvement and the other person has essentially none. So it's quite variable, even within a family, who's going to have the liver involvement. As I said, in most people, it doesn't impact their liver function. Your liver is very good at, even if it develops cysts or problems, your liver is very good at regenerating and has capacity, a lot of backup. So a lot of people, even if they have massive livers that are 10 times the normal size, the liver can still work, it can still do its job. But some people will go to the point where they either need a surgery or, in rare cases, even something like a transplant as a result of that. So it's a quite variable one. Yeah.
As you mentioned earlier, that with cysts there are chances of having stones too. So what are your recommendation for those stones? Should we go for lithotripsy and all these kind of things?
With kidney stones, the question was, should you go for a lithotripsy or anything like that? That's definitely a case-by-case kind of a thing. Some stones cause problems. Some stones happily sit in a place and never cause an issue. So that's I wouldn't hazard a guess on that. That's something we decide based on exactly what it looks like, what the stone is doing. So this is the liver. So, and I know there are people even in this room who are quite affected by this. The other big kind of outside of the kidney thing we talk about is aneurysms. This is something that may be brought up. What an aneurysm is it's a blood vessel. You see that blood vessel in the middle? It should look like a nice straight line or like a drinking straw or something like that. The aneurysm is that bubble in the middle, where it's a place where the wall of the blood vessel gets a little bit weak and can grow. Why we care about that is that if that bubble gets too big, it can also pop. And where we care about that happening is in the brain. If you have a bubble pop of a blood vessel in your brain, it can be a very, very bad thing. So because of that, we get in a habit of talking and screening people who might have this. So what we mean by screening is doing testing before it's ever a problem. So aneurysms are things that happen in the general population. Some people, in the general population will have it, but it's much more common in people who have polycystic disease. The biggest risk factor for having an aneurysm is having someone in your family who's already had an aneurysm. So we say anybody who's had a family member who knows that they've had an aneurysm or something like, people might not know it was an aneurysm, so other things we ask about are things like unexpected strokes at an early age or unexpected or sudden death at an early age. I had an uncle so-and-so who dropped dead at 45 years old and nobody knew why. Those are signs that there may have been a family history of aneurysm, and definitely anybody who comes from a family like that needs to be tested. For people who don't have that family background, we talk to people one-to-one about it, but still most of us would just do the test because it's a very low risk thing to do the test. The more important thing is then us knowing what to do with it afterwards. The vast majority of these aneurysms we find, we don't have to do anything about. We watch them over time to make sure they're not changing, but just knowing about it before it becomes a problem is the important thing. There were a couple questions. Oh, yes. Oh, yes. Sorry, that's a good question. So the question was, there's two. So one is an uncle, close enough relative that we should be looking at it, and the second question was about abdominal aneurysm. I should mention also the second question first. This is what we call intracranial aneurysms. Something like abdominal aneurysms can happen, but the confusing thing there is that abdominal aneurysms are also just common in the population, whereas this in the general population, whereas this is very specifically an intracranial aneurysm. And as far as how close of a family member, anyone within the family who is known to have the cyst in their kidney, or from a family that has polycystic disease, because it's not just that they had an aneurysm, it's that they had an aneurysm and have polycystic disease, that's what says, okay, now the risk is very high. So in people who, so the question is if there's no family history, how common is it? So in people just with polycystic disease in general, it's a couple of percent of the population, so somewhere between 2 to 5% or something like that, depending on the study. If there's a family member who has an aneurysm, it's closer to 20% of those people will have aneurysms. So it jumps through the roof as soon as it's a family member. So that's why we say if you have a family member, you must be screened. My general take is that even if you don't have a family member, you probably should be screened because it's an easy enough test. It's just more to know what to do with it. And we recently met about this in BC, and most of us are saying that actually we just test everybody because there's little downside in doing a test. It's more just knowing what to do with that information and how we follow it over time and things like that. Is there? Oh yeah, in that side of the room, I really can't tell if hands are going up because I just see it's like a deer in the headlights. That's all I see over there. But yes, go on. With these tests, with the aneurysm tests. So in general, if one is negative, I would say the warranty on that is at least 5 years. It's very rare. If someone's had a negative test, it's actually only about 1% of people will ever develop an aneurysm later on. But we still, because 1%, it can be a devastating thing. We still do it. We generally would say, and again, case by case, individual to individual, we would say somewhere around 5 to 10 years you would think about repeating it. If there's nothing there, it's quite a while before you have to do the next one. So we've kind of been asking questions as we go along in this section, and then the last part is kind of the smaller section, but I'm not sure if anyone has any burning questions that we haven't addressed as we've gone forward here. I'm just screening the list here, and we've kind of covered most of those. Alcohol, that's a question that comes up too. Can I drink alcohol? The answer is yes, but not a lot. In other words, sometimes people, I think, come looking, for carte blanche to go have whatever they want. I'd say, 1 to 2 drinks now and again is okay. 10 drinks is not okay. So as anything else, it's moderation, but it's not like one or two is going to affect anything. And I think we've covered a lot of the other ones. And sorry, was there a question?
So what are signs and symptoms of cyst infection?
So the question was, what are the signs and symptoms of cyst infection? So when the cysts actually get infected, that could be quite a big infection. So in other words, it's not a subtle thing. Pain, high fevers, really feeling unwell. It's not something that you wouldn't know about. There would definitely be symptoms that come out. Sorry. And I think we covered all the rest of those. Okay, so in our last section, we're getting on the home stretch here. I know you guys have been such a great audience here as we talk about it. So the next one's kind of the long-term outcome. So a couple of things here. So as time goes on, the kidney function with polycystic disease will go down. But there's a few things I want to say about it. I love this picture. I show this picture anytime I do any talk, and it really outlines what happens with polycystic disease. It shows that as time goes on, the kidneys accumulate more cysts, the cysts get bigger, and the kidneys as a result get bigger in size. And then eventually that red line is meant to represent kidney function. And the interesting thing here, and this is variable, the one thing I really actually don't like about this picture, although I show it all the time, is the numbers at the bottom, because this time is different for everybody else. So I would just put your hand over those numbers, because that part I think is different for different individuals. But the general course is correct in that first the kidneys get bigger, the kidney function stays stable for a very long time, and then it drops off towards the end of the disease. So the important thing is that early on in the disease, there may not be a lot of symptoms. And actually, if you look at that picture with the red line, early on in the disease, the kidney function's perfectly fine, perfectly normal. So if all we did was go along and look at the kidney function, we may see that for the majority of the disease, it's staying normal, but that's when the disease is actually happening. That's when things are happening. So just monitoring the kidney function isn't enough. But then we talk about what happens in the later stage of the disease, and the kidney function does start to go down. There's symptoms here that are listed about how can I know if my kidney function is declining, and the short, somewhat tongue-in-cheek answer that I'm going to give you is that you'll know by doing the tests. And I say that for a reason. There's symptoms listed at the bottom for if your kidneys aren't working, but that doesn't happen until very late. The rule of thumb that we use is that you can lose 80 to 90% of your kidney function and never even know it. You wouldn't feel anything. It's not going to make you sick. Your kidneys are built with a lot of backup, a lot of reserve, so that if the function drops down, they can still keep doing their job. And so that's why we focus on getting regular tests, because the tests would tell us way before then, way before symptoms arise, the tests would tell us what's happening with the kidney function. So that part's very important. Yes, there are symptoms that come up as the kidney function goes down, but the tests will tell us that beforehand. Now this part we kind of introduce what are the options here if the kidneys aren't working. So we'll talk about dialysis and we'll talk about transplant. It's worth mentioning these words. These are words people have heard. Sometimes they're kind of scary things to talk about, especially if things are going well, but it's important to talk about. The one thing I would say on this slide is the slide is backwards in that transplant is the preferred option and should be up front. We have it written there, but it should be on top. And then dialysis is an option where we essentially take over the function of the kidneys. So we can talk, I'm going to introduce this a bit. I don't want to spend a lot of time dwelling on this because this is some of the things that you'll talk about in a lot more detail with your kidney doctors and a lot of individual, but just to raise the idea of what these treatments are. So when we talk about dialysis, we talk about two kinds of dialysis. There's one called hemodialysis, or where we clean the blood directly. This is essentially where we use a machine to do the job that the kidneys aren't able to do. Very importantly, when we talk about dialysis, these are treatments that do not fix kidneys. They do not help the kidneys recover or anything like that. They replace the kidneys when the kidneys aren't doing the job anymore. And hemodialysis is a setup where we do this with direct access to the bloodstream. So we actually take somebody's blood, turn it, take it out of their body, it goes through a machine that processes it and return it back to their body. There are different ways of doing hemodialysis. People can come into a center where we do it, or we have people who actually do this at home, where people can do the treatments themselves. So we're just introducing these. That's hemodialysis. Peritoneal dialysis is our other kind of dialysis. That's where we use the body's peritoneal membrane. That's where that word comes from. It's a part of your body inside the abdominal cavity, inside the stomach there, where we can put a tube in, and we use fluid that we put in and out to then remove those wastes. I think that this is important to mention because, and this is peritoneal dialysis is a treatment that's always done by people at home. I think it's an important thing to mention because in some places they would say that people who has polycystic disease cannot have peritoneal dialysis. Some places, some parts of the world, they actually have that as a rule. You can't do it because your organs are already enlarged and there's just no way that can happen. Now, it's true that it can be trickier, and there are some people whose organs are so enlarged we cannot do peritoneal dialysis, but definitely not everyone. And in BC, we're very good at this. We definitely have a good group of people who have polycystic disease who are doing peritoneal dialysis. So it's still on the table. Some places will tell you that's not the case, and I would say that's untrue. We have a good group of people here who are doing it. It just takes some individual decisions. And then we have a few slides to talk about transplant. So I think this is the one that's kind of worth thinking about more. So transplant is the best treatment if your own kidneys are no longer working. So our dialysis setups can kind of mimic a little bit about what a kidney can do, but a kidney that's transplanted into somebody is light years better than we will ever be. So transplant is the preferred option. People live longer, feel better, and do better as long as they're candidates for transplant. A few things I want to mention about transplant. So one is the question I get asked all the time. is if somebody has polycystic disease and then has a transplant, is the polycystic disease going to happen in the transplant? I get asked that all the time, and the answer is definitively no. 0, 0, 0, 0. That is not going to happen. So the polycystic disease is about the genes that's embedded in your own kidneys, but a different kidney that does not have those genes is never going to be affected. It's worth mentioning because I've met some of my patients, I've had transplant for 10 years and then ask, oh, well, when is this going to happen in my new kidney? Like it's been hanging over their head, that they're just waiting for the sword to drop. And that's not the case. It will not recur in the new kidney. We talk about doing this early as possible, and that's important because it takes time to do all the testing and workup, and especially important, I think, if you have polycystic disease, just because a lot of the people who we might talk about donating, a lot of your donor pool, your family, may also be affected. So it sometimes takes a little bit more looking and a little bit more planning. I'm not going to get into too much detail about these just because it's something that each group will talk about, but basically what happens is if you're going down this road, you'll be referred to a transplant center and they'll do testing to see if people are a good fit. They'll do testing both for the person who's going to be receiving the kidney and testing for anybody who's thinking about donating the kidney. It's obviously a big question that people ask about when they're thinking about having someone donate to them as well. Is it going to be safe for that person who's doing it? It's always on the top of people's minds. And I want to say that when someone's going to donate, we put them through the ringer. So we make sure that people are the healthiest of the healthy before we let them do this, because we want to make sure that there's going to be no risk to them. And part of the first part of this process when you're going down this road is you'll meet with the transplant team and just talk about this and get all the information about what actually is the risk, what actually is the donor taking on, what are we talking about. So in other words, when you get referred to meet a transplant team, you're not signing up for anything or right away or that day or anything like that. You're going to talk about it first and go over all these details. There's a few oh, yes?
I have a question about kidney donation.
Sure.
And the age of the donation person. So like
Sure.
Let's say we're a couple.
Sure.
And I want to donate a kidney to her. As her kidney function declines, we're getting older together. Is there some sort of limit to the age at which you...
So the question was, is there limits to ages of donation? Actually, we had this conversation before the talk even started. This question came up too. And there are some, but it's a bit of a sliding target. And what I mean by that is, it might sound funny, but we actually prefer older donors. And the reason for this is when we're looking, and I won't get into all the details, but and it's not to say someone can't donate when they're younger, but people might say, oh, if I get too old, I can't donate. Actually, in some places, it's somewhat the other way around. And because when we're looking at the risk to somebody of donating a kidney, one of the biggest things we're talking about is what's going to happen to that person in the future. So if you've given away half of your kidney function, one of your kidneys, the one risk we know is that you're more susceptible if something else happens to you. You've kind of lost some of your backup, so your kidney function might go down. So we're thinking about what's going to happen to that person. So if you donate when you're 20 years old, you have presumably 60 plus years ahead of you where who knows what's going to happen. Whereas if you've made it into kind of some of your later years and are in good health, you've kind of passed the test of time, as we say it. Meaning that if you've made it to later in life and you're healthy and don't have high blood pressure and don't have diabetes and everything is going well, it's less likely something's going to happen to you than that 20-year-old who we don't know what's going to happen. So the short answer is no, there's no age limit. And I think, I don't want to get too much into donor selection, but what I would say is if you're talking about transplant and if you're talking to people about donating, have people come forward. Let the transplant team do the testing. Sometimes people eliminate possible donors in their own mind before they even come. Let that testing happen, and then you can see what shakes out at the end of it. Yeah. But it's a very good question. There's a few last things. I don't want to get into too much detail about this, but we have programs in place in Canada. We're actually leaders of this in Canada, where we get people transplanted who otherwise couldn't. We have what's called a highly sensitized program, meaning somebody who's built up a lot of antibodies, who would be at risk of rejecting a lot of different kidneys. We have ways across Canada of getting those people transplanted. I won't get into details, but I can tell you that since this has been in effect, we've transplanted people who we used to say, frankly, you will never get a transplant because they had so many antibodies. Those people have now had transplants. We also have something called kidney paired donation, which I'll just briefly touch on here. This is important because when people are talking about donating, they think, oh, I've got to go find a family member or a blood relative or someone with the same blood group and they can donate to me. And the answer is that's not the case. We have a system in place where, so people do better if their transplant is of the same blood group. So we have a system in place in Canada where, say, if you're a blood group O and your donor is blood group A, you can't take a kidney from that person. We have a system in place where then we would say, okay, right, that's the two of you. We'll enter you in a big computer system that then looks for somebody in Canada who has the opposite problem. And then everybody swaps. We call that's why it's called the kidney exchange, paired kidney exchange, and everybody gets the transplant. And so everybody wins. And that also is helping us transplant people who otherwise wouldn't have got transplants before. What the heck is happening here? Why did that happen? I could tell it was doing something. Oh, have I broken it completely? Let's see. Oh, I've broken it. Oh, I fixed it. Okay. All by myself. This is the first time today I've fixed the computer by myself. Oh, and sorry, there was a question. Yes. Yes. We're big participants in this. Oh, sorry, the question is this Canada-wide? The answer is yes. We're huge participants in this in BC. We contribute some of the most numbers of people to this. And so it may be that people switch kidneys with people on the other side of the country. A lot of it does tend to happen just within BC, though, because we do so many of them. But yes, it's both of those programs I talked about are across Canada. And that's how, by opening up, increasing the pool of available donors, that's how more people get transplanted and we can make these things happen. So those were just some general overviews. I mean, that was the last bit of the content, but a few other things I want to point out once again in terms of resources. Great things. The PKD Foundation, I couldn't say enough good things about the information that's up there. And then there are specific different resources about some of these other programs. I'll plug BC Transplant just because I know the materials they have on there are excellent, but all of these are good sources. I just happen to know all the BC Transplant materials, and it's a very good one. But places you can look for more information. And that was actually the last section of content we have. And at this point, we'll kind of open it back up to any questions either about this section or anything we've covered today. I think there's someone by the light back there. Yeah, I really can't see that area. I'm sorry, guys. Okay, yes.
Is donor match, is it mainly blood type?
The question is the donor match mainly blood type? I would say that's the first level of matching, but then it does go much more detailed than that. And again, without getting into the details, and it's not that I'm just trying to gloss over things, it's something I tell people not to think about when they're talking to donors. What you need is just somebody who appears to be in good health as far as you know. They seem to be in good enough health and they're willing, and then let the transplant team do the rest. Let the transplant team, there is complicated matching things they do. There's people who spend all day, very smart people, smarter than me, who think about this all day long, and let them do that. So as long as someone seems willing enough and no obvious problems with their health, have them come forward. Great. Any other questions, not just about transplant or anything else that we've covered here? Otherwise, yeah, Kate. When do people usually get referred to transplant was the question. So it varies from place to place. In BC, we've just recently started up over the last year with an initiative we call Transplant First. It's the goal of doing this early, knowing that transplant is the best kind of treatment for those who it's an option for. It's not an option for everyone, but for those who it is, since it's the best kind of treatment, we focus on doing this early, giving people time. It's a process that takes time, not just from the medical side in terms of doing the testing and everything, but it takes time as a person doing this to go out, get the word out, do your outreach and talk to people, think about how you're going to do this. That all takes time. So we've started trying to do this earlier. And our general rule of thumb that we're saying now within our kidney clinics in BC is that when someone's kidney level or GFR number is somewhere about 25, that's when we start talking about it. But it might differ for different people. So that's the general rule of thumb. It's something that you'll do in concert with your own nephrologist. And it's never a bad thing if you want to bring that up and ask. Sometimes people feel afraid to ask about it, but they've been thinking about it a lot. And just ask your nephrologist. That's what we're here for. Yeah, any other questions at all? I think there's, yes, there is one. Oh, no, it's fine.
I was interested to see that you listed like the liver specialist and nephrologist, and it's been my experience that I've got an excellent nephrologist, but it seems like the care, and even the conversation with the transplant agency, it seems like it's kidney specific, and so I really appreciate commenting on the hepatologist. And so is it our GP who's supposed, not supposed to, but the one with the mandate to kind of connect and help you connect with all the specialists?
Right. So the question was about other specialists who might be involved, particularly hepatologists or liver specialists, and where do they come into the picture? I would say honestly, it's something that is sometimes a bit of a gap, or maybe our liver care is not quite up to where our kidney care is. I would say with this, and not for lack of people not trying or anything like that. It's a difficult thing to manage. But that said, we definitely do more and more. We're involving both our hepatologists, our liver specialists, and people like hepatobiliary surgeons, the surgeons who might do things like this. And in terms of who would do that, it's a different mix. Some people, might see someone like that through their family physician, might set it up, or it might be the kidney specialist. Again, if you have concerns about the liver, I think it's perfectly fine to take it to your kidney specialist to talk about as a starting point, because we do tend to know more about this than the average person. Yeah.
And then the cardiologist too, in terms of valves?
So the question was a cardiologist. One of the possible complications of polycystic disease is a valve abnormality. Definitely not everybody needs to be tested for that. We kind of do that based on when we examine somebody or if they have symptoms. If they happen to have one of those valves, then yes, a cardiologist could be involved. Most of those valves tend to be abnormal, actually tend to be of little consequence. It's people can happily live their lives with it. But yes, if needed, they would be involved. I think, in general, your family physician is often the quarterback of your care team, as we say. But anytime you have questions specific about polycystic disease, I think it's also very fair to bring it to your kidney specialist, because we do tend to know more about it than the average person. Oh, yep.
Is there some correlation between polycystic and cholesterol level?
The question was, is there a correlation between polycystic disease and cholesterol level? The answer is maybe. And I'm not just trying to duck the question. It's something that people are really looking into, because we know one of the things that happens early in polycystic disease is changes in the blood vessels in the kidney. And not aside from just cholesterol, that might be we call it a blood vessel, a vascular kind of a problem. So the jury's still out on that one in terms of how it affects the kidney. Definitely anybody with any kidney disease, anything going on in their kidney, is already at higher risk of having problems with the heart. So it's something we think of in everybody who has kidney disease. And again, if you have questions, something you can bring up with your family doctor.
So you gave a timeline of different drugs and treatments that have happened with PKD, and you highlighted just one of the drugs, which is tolvaptan, which is the only one that's approved. You said that there's many other, and they would show up like dots on
Yes.
the graph. Is there any that are fairly far along that may come into?
So the question was in terms of other drugs in the pipeline, and where do those stand? Because I mentioned that this is all being studied now. So there were a couple. One of them disappointingly didn't pan out. One that we had high hopes for, actually, a group of treatments didn't. It turned out that it kind of worked for the kidneys, but we near killed people with side effects, which doesn't sound like a good thing to do to people. So it's one of these things where sometimes it shows that the research pathway itself is a hard one. Sometimes we think that sound excellent on paper, and then we study it turns out to not pan out. There's, I would say, two more that are getting close, and we'll have to wait and see. They're not at the point where they're indicated, or even, at least right now, we're not doing any studies on that we're active in BC for. But I think there's a couple that are close. I think if we're looking at this over the 10-year frame, the 10-year horizon, that's when we'll start to see some of these other things. Yeah. Oh, yeah.
When can I get on a wait list for a transplant?
As far as transplant goes, so when you hear about this wait list, that refers to, and I didn't want to go too much into detail of transplant, but the 10,000 mile view is that there's two different ways somebody can get a transplant. What we've been talking about is a living donor transplant. Somebody donates directly to you. There's also what's called a deceased donor transplant. That's where somebody who passed away indicates that they want to donate their kidney, and you can get a kidney that way. The wait list refers to the deceased donor transplant. For a living donor, there is no wait list because this is somebody who said, I want to donate directly to you, and then away you go. For the deceased donor transplant, for it to be fair, it needs to be a set time, and the way we start this everywhere in Canada is that your time on the waiting list starts when you start dialysis. So you may see in places, if you look on things online, they talk about places in the States where you can be on a wait list before you start dialysis. This is not the case in Canada, where there's more people waiting for a transplant than there are available. So this is why it happens after someone started dialysis.
Another question to that area. Typically when a transplant happens, the donated kidney gets added to the person that's receiving the kidney, and the other kidneys are typically left there. With the polycystic kidney disease, will those cysts and kidneys continue to grow? And do you take one out or sometimes both of them?
So there's a couple of fold question there. So the question was about when somebody has a transplant, what happens to the existing kidneys? So the first question was, do they continue to grow? The answer is somewhat, but they eventually do level off. They don't just get bigger and bigger and bigger like a balloon, continuously blowing up over the course of their lives, because eventually it gets to a point where there's so many cysts, it's gotten about as big as you can get, and the kidney actually relies on some function to make those cysts grow. So eventually they do tend to plateau out. And then some people actually start to shrink as they kind of no longer work. So they don't just keep growing and growing forever after someone's had a transplant. The second question is, do they take the kidneys out when someone's had a transplant? And I'd say the answer is sometimes. It's not always, because it's actually, in a lot of ways, a bigger surgery to take those old kidneys out than it is to put a transplant in. So it makes it a bigger and riskier operation. In BC, we have actually now it's up to more than two, but we have excellent surgeons who do this, where they can take it out with what we call minimally invasive. And I still describe it, it's almost like a magic trick where they can take out a football-sized kidney out of an incision this big, but they can do it with minimally invasive surgery now. And so with BC, we do more of this than a lot of other places where they might take it out, but it's a very, very individual discussion with the surgeon at the time of. Great. I don't know if there's any other questions. Otherwise, I'll be up here. Oh, yes.
How often does PKD affect parathyroid hormones, and what is the impact of that?
The question about PKD and parathyroid, does it affect parathyroid hormones? Anybody who has any kidney disease, it can. And yes, we have various treatments that we can use to do this. I'd say there's medications, there's other things we can do with parathyroid. It's a complication not just of PKD, of any kidney disease, something that tends to happen as the kidney function goes down. And I won't get into too much of the specifics of it, something to talk about with your kidney team. But it's not a PKD specific thing. Great. Otherwise, I mean, that's just flown by, and we're at time here now. But I'll definitely be up here if people have any kind of last-minute burning questions they didn't want to share with the group or anything. Otherwise, I mean, thank you for your attention. This was amazing. Probably one of the most engaged groups I've ever talked to. And to listen to me ramble on for 2 hours like this and pay attention is fantastic. So thanks, guys, for being such a good audience here.